My name is Nan Taylor, and I work for Aspirus. I am the Director of Business Development and Community Relations, so you may wonder what I'm doing up here tonight. Well, a couple of years ago, we decided, oh, that was loud. We decided that women needed the opportunity to be empowered and inspired to really change their lives and their health. And we felt that the way to do that was to have these fun girls' night outs where we would feature different topics that pertain to the health of women and to the health of their families. And so we welcome you tonight to our inaugural event in Point. We will be having events in Point, and those of you who have signed cards or indicated that you want to be an Aspiring Women member will get invitations to the event. I also invite you to visit our landing page, which is on the Aspirus website, aspirus.org. If you scroll down to the bottom of that page, there's a little white daisy, and click on that for the Aspiring Women landing page. You'll see events that are happening throughout the Aspirus system, whether it's Langlade or Medford or Wausau itself. You will get access to our online magazine. There's recipes on there. There's health tip articles. So it's just full of a lot of things that would be interesting for women. Aspiring Women is really a national organization, and it's a coalition of healthcare providers across the entire United States who come together and try to deliver these programs for women, and every so often for men. Not often, but every so often. So I want to start out tonight first by introducing you to our presenters, and then they're actually letting me present a few slides, which is unusual, but I'm happy to do so. So our topic tonight is south of your border, and we all can relate to that, can't we? And speaking tonight will be Dr. Bonita Kolrud. So the facts that you should know about Dr. Kolrud is that she went to medical school at the University of North Dakota, and she did her residency at Baylor College of Medicine in Houston. She's a board-certified obstetrician and gynecologist. She and her husband have 3 children together and 1 grandchild who lives just down the street, which is very nice. They love the outdoors, and Dr. Kolrud actually started her practice in Denver, Colorado, and then decided to move east. She had a daughter and future son-in-law who were moving to Minnesota, and they felt like Wisconsin Rapids was close, but not too close. How perfect is that? So she has been with Aspirus for 3 years. She enjoys the outdoors and walking her dog, Toby, which is a chow. Dr. Jenna Kalaji, you may know the name Kalaji because she is a native of Stevens Point. She got her degree she attended medical school at the Midwestern University of Arizona College of Osteopathic Medicine. She did her residencies at Grandview Southview Medical Center as well as Kettering Health Network. She is board eligible. In fact, she just returned this week from her boards, and we know she knocked them out of the ballpark, no doubt about it. She's also a newlywed. She joined us last fall and became a newlywed shortly thereafter. I don't know how you graduate from your residency, start a new job, and then decide to get married in the same month. She loves to garden, and she and her husband put up hundreds of jars of salsa, which I think is very fun. They have 2 dogs, boxer mixes, that are named Mo and Rocky. They're both rescue dogs. She joined Aspirus at the Stevens Point Clinic, but also practices in Wisconsin Rapids. Also joining us tonight is Phyllis Lehman, who is a physical therapist at Aspirus Riverview Hospital and Clinics. She has been there, although you will not guess it by looking at Phyllis. She's been there 25 years, she tells me. She is a graduate of UW-Madison. She's all about being a Badger. She has 2 dogs, Biscuit and Daisy, both labs. She has 2 children, a daughter who is in her junior year at Viterbo and an independent adult son. So he's a taxpayer. All things are good. She loves to walk, camp, and travel. So the way this evening's going to work, I'm going to start. We're going to have the presentation. Afterwards, don't rush out because we have door prizes. We have also an Aspiring Women gift. But before I go any farther, we have something that is so special about these events. And I would like to introduce you to, for only their second time only singing for our event, our aspiring a cappella group. Please come forward, ladies. These ladies all work for Aspirus, and they discovered each other kind of in an interesting way that they all loved to sing, and then they were singing at a birthday party, and a fourth one joined them, and they all sing different parts, and it was amazing. So first up is Peggy King. She is the executive assistant to our CEO. Next is Kathleen Orminski, who is the director of the emergency department. Then we have Rhonda Alf, who is the administrative assistant to the Quality Improvement Department. And last but not least, we have Cindy Orzel, the very talented wordsmith, Cindy Orzel, who is our HR business partner. Now what these ladies do for us is they take the theme and they pick a song using the tune of that song, but they change up the words that have, so it applies to the theme. So please, that's our talented wordsmith there at the end. So please enjoy the Aspiring a cappella group.
At first I was afraid, I was petrified. My mother said I was a woman, she was filled with pride. But then the cramps were setting in, my emotions running high. I used to cry and didn't even know why. Hormones were high, they were high. 42 was 32. I was scared that puberty would be so hard on you. How are my pants feeling so tight? How did his hair get on my chin? With all these changes going on, I wasn't sure how I would win. And now I'm off. And now she's off to my exam. To her exam. Have another pap smear or a mammogram. Weren't you the one who said I might pee when I sneeze? Or have a hot flash? Hot flash. Oh, Dr. Pretty, please. Oh, no, not I. Oh, no, not I. I will survive. I will survive. Oh, as long as there is Tylenol, I know I'll stay alive. I've got all my life to live until the menopause sets in. I will survive. I will survive. I will survive. I will survive,
Thank you, Peggy, Kathleen, Rhonda, and Cindy. Aren't they great? They're giving autographs afterwards. And if you're going to try to book them, you have to go through their manager. I don't know if Mary, manager, is in the room, but that's who you have to talk to. Oh, she's over there. Okay, so let's get started. Okay, so south of your border. We all know what that pertains to. So, ladies, did you know that half of all women, I think it's probably higher, have never talked to their doctor about care management or treatment of pelvic health conditions? Why is that? Because they're men? The doctors are men? Well, they won't be tonight. Half of all women don't believe that pelvic health disorders are a normal part of aging, are an inevitable consequence of childbirth, are an acceptable consequence of changes due to menopause. Have any of you ever experienced embarrassing accidents, heavy menstrual periods, or irregular periods, uncomfortable intercourse? Here is what we're going to talk about today. how to be patient with fibroids, keeping your perimenopause in balance, effective treatments for urinary incontinence that can help you get some consistency back in your life, and gathering your momentum to ask questions you have always been afraid to ask. It's all among women here tonight, ladies. So I just want to talk about one thing before I turn it over to our experts. I want to talk about 7 reasons to celebrate getting older. There's a lot of talk about aging these days. We say things like the 30 is the new 50 and the 40 is the new 60. I know, I've heard it. I kind of like it. And we also hear you are only as old as you feel. While both of these statements in many cases are true, there are times they make me cringe a little. And the reason is the underlying message is this: it is no fun to be older. Ladies, that just isn't the case. There are actually parts of being older that I find an improvement over being younger. The first one is that I no longer have to have a clothing crisis or a fashion crisis. When I was in my 20s and 30s, all career paths for women were paved with dresses and pantyhose that would frequently run at inappropriate times. In fact, I carried a spare pair in my purse. When I was climbing the career ladder, figuring out what to wear for job interviews would throw me into a tailspin. Did I really believe that carrying the wrong purse somehow made me less qualified for the job I wanted? With age came confidence that I really do know how to dress. Number 2, I now know how to compromise without being compromised. With age comes the skill to navigate around challenging personalities. And I now know how to prevent discussions from escalating into full-scale wars. I still have opinions. I just accept that not everyone shares them. As you age, it becomes far less important to be right and way more important to be happy. I love discussions, even debates. I am fine with a disagreement as long as it isn't disagreeable. I also know that you can't just say no, or you should just say no. While Nancy Reagan's message was intended to dissuade kids from trying drugs and failed miserably, I'm afraid, the ability to say no grows with age and absolutely has its upsides. I am learning, and I say learning because my coworkers would tell me I have not learned it yet. I am learning to decline invitations to things I just don't want to do. I am learning to say no to people who try to pressure me into doing things or support causes I don't want to. I am learning that I can say yes to having more time with my family and my friends. I no longer feel the need to be invincible. My downhill ski life ended after my second hip surgery 12 years ago. Now, I someday will venture down a bunny slope, especially if I ever get to have grandchildren, but I much prefer the relative safety of snowshoeing to skiing moguls. I'm good with it. I have ways of staying in shape and having fun that feel a lot less risky to me. I have no interest in jumping out of airplanes or surfing the waves at Oahu's North Store. In fact, my thrill bar is set pretty low these days. Put me on a hiking trail with a couple of girlfriends, and let's reserve a table at a great new restaurant for dinner, and you have just made me really happy. Principles don't soften, but we may. I heard about a person who quit his job over a principal. He was a teacher at a high school, and he caught a senior cheating on a final exam and gave him an F. Well, that F affected the boy's acceptance to college and really put his admission at risk. The boy and his parents pleaded for mercy, first to my friend and then to the school's principal. And when the school asked this man to change the grade, he refused and quit on the spot. Cheating is despicable, he said. And while ruining a kid's college plans is a steep penalty to pay, a worse lesson was believing that you could cheat in life and get away with it. For years, I admired his resolution to stand up for what he believed was right. It wasn't until I had my own really imperfect children that I wondered how quitting his job had helped this boy who clearly needed help. Truth is, it hadn't. Sometimes it isn't about us, but our willingness to forgive and bend. Doing the obvious thing isn't always doing the right thing. I can be soft now. While I didn't spend my 20s, 30s walking around feeling fierce, I suspect that's how I appeared to most people. Being a woman trying to advance in a male-dominated workplace required a certain toughness. I'm glad that I don't have to be that person anymore. I would rather woo you than scare you. I would rather inspire you than intimidate you. I am actually happiest when we learn from each other. And finally, with age comes your own washer and dryer. Now, maybe you think that's silly, but there are just a few life conveniences that wallop the same punch. There are few life conveniences that wallop the same punch as in-home washing machines and clothes dryers. These appliances totally remove the chore from doing laundry, well, sort of, and eliminate the need to own 30 pairs of underwear. The joy of being able to toss a few things into the washing machine while dinner is cooking and then move them to the dryer before going to bed is never to be underestimated. I have a last page and a last thought. But here is the broader lesson. By the time you reach midlife, you have figured out how to make your life easier. While complexity makes life more interesting, inconvenience does not. And so, please give a welcoming hand to Dr. Jenna Kalaji. There you go.
Okay, just click.
This one right there.
Perfect. All right, well, thanks, Nan. That was great. We're going to start with the basics for you guys tonight. I hope everyone can see the slide. When I get patients that come in, if you are one of my patients, you might have heard me see and refer to all the posters on my wall. And we first start with talking about anatomy. So that you have an understanding as I explain things further down the line. So here is what we want you guys to understand about the reproductive system, the pelvis, and the pelvic floor. So the female reproductive system consists of internal organs and external organs. This is a picture of your internal organs. So we talk about your uterus, your fallopian tubes, your ovaries. We talk about the cervix, and then we talk about the vagina. We talk about the hymen, if we're talking about painful intercourse. External organs are the labia, the vulva. Those are the organs when we're referring from internal to external. They all are part of reproductive health, and they all are part of playing a role together to prevent pelvic pain, stress urinary incontinence, things like that. So it's really important to have a basic understanding of what the anatomy is so that we can educate you to make the proper decisions when we have treatment options that sound best for you. The next thing that we talk about when we're talking about, perimenopause, menopause, postmenopause, we talk about hormones, fun hormones conversation that we get to have. There's two important hormones that we first start talking about, FSH and LH. They're produced by the pituitary gland, and they act on your reproductive organs, on the ovaries, mostly to produce progesterone and estrogen. These components play a key part in what causes some of the symptoms and the complaints that we hear a lot. So these are the hormones that we normally refer to, and although it says 2, there are 4. So FSH, LH, progesterone, and estrogen. One of the complaints we often see in women's health is the complaint of fibroids. I get referrals all the time from primary care doctors, or patients come in, transfers from out of state. I have fibroids. What should I be worried about? What should I do? I just don't know much about this. So we start off with just basic knowledge. They're benign growths. It's a growth in the muscle of the uterus. They're very common. 75% of women have fibroids, but only 30% are large enough to detect actually on ultrasound. Up to 80% of these cause no symptoms and require no treatment. So a lot of times it's just reassurance that everything's okay. Symptoms, if you come in, you're normally complaining of heavy periods. They may last long. You'll notice that you're having pelvic pressure, pelvic pain, or you come in telling me, I have to urinate all the time. This is a problem for me. The causes, it's really unknown, but we believe that estrogen and progesterone play a part because we know that that's what's necessary for our fibroid to grow. After menopause, when those decrease, the fibroids no longer grow. So risk factors for it. This is something that we see with age. So as we age, that's as they grow, they finally are detectable. Another thing, family history plays a part into this. People come in and say, oh, my mom, my grandma, my great-grandma, they had fibroids. Now they have fibroids. Yes, it's true. There is a component with your family history that we look at. Also, obesity plays a factor into that. Obesity, you have more estrogen in your body. More estrogen causes growth of the fibroids, and that's what we see. Treatments. There's lots of different treatments, and we try to go over every option that fits best with the patient, and everything's individualized. So we have watchful waiting, we have medications that we can give you to try to help with the symptoms, and we have various procedures and surgical options if that's what you wish, or if you failed the medications and different aspects like that. Another cause that we get, our complaint, is menopause. I think I see this daily, if not more than 20 to 30% of my patients come in complaining of perimenopause or postmenopause or menopause, and they don't know what the true definition is, but they're not happy. And that's what it comes down to. I'm just not happy, please help me. Okay, so perimenopause, that's the transition phase. It's the years leading up to menopause and the first years after your period. Physical signs of menopause begin many years before the final menstrual period. Hot flashes, night sweats, mood swings, vaginal dryness, irritability, all that is part of that. Menopause, the true definition is defined as no periods for 1 year or 12 months. And postmenopause is a span after menopause, when most of your menopausal changes have started to fade, hopefully for everybody. So let's talk about this. So perimenopause, like we said, knowing the symptoms. You have irregular menses, hot flashes, you just can't take it anymore. You haven't slept in days, you're crabby, you're waking up in night sweats telling me I gotta change my pajamas 3 times, I can't deal with this. I have vaginal dryness, there's itching, there's burning, I can't have intercourse anymore. I have mood swings, my family doesn't even like me. My husband won't even talk to me, and my kids run out the door when I walk in. Okay, I hear this daily, I understand. They also tell me about depression. I don't like the way I feel. I've been dealing with this for a long time. Is this normal? Should I talk to you? Is there anything you can do? Maybe I'm just making it up. Yes, there are things. So discuss these symptoms with your doctor, okay? There are lots of different treatment plans that we can come up with. We come up with a plan together so that you're happy. We try to relieve whatever symptoms are bothering you the most. It's not a one shot fits everybody type of thing. So please write down the symptoms and let us know. So with that being said, a symptom diary is very helpful. Because most people come in and they forget about something that they wanted to tell me about. But if they come in with a list, basically, or a log, saying, oh yeah, I do have night sweats, or yeah, my periods have been irregular, they were going farther apart, I had one every 40 days, now they're every 10, and my flow has changed, and this is something I can review to figure out what exactly is going on and how I can help you. The other thing that we talk about is embracing healthy lifestyle changes. This goes for just health in general. I mean, it definitely helps when you're going through the perimenopause phase. Exercise, talking with friends, dressing in layers, because if you have those hot flashes and you're in public, you're going to need to take off things in order to not die. Stop smoking if you're a smoker. Limit your alcohol and spicy foods. Try to maintain a normal body weight and take care of your skin. Those are all things that we can do for general health, not just for postmental or perimenopausal changes. So what else can be done? We have hormone replacement therapy. There's lots of different options. Our goal is to use the lowest dose possible to treat your symptoms for the shortest duration. We have oral medication, we have creams, we have patches. Everything is based on you and your history and if you're a candidate for these. So these are questions that we're going to ask you lots of things back before we come up with a treatment plan. It's not as easy as saying, just take this pill, it'll fix it. We have to talk about a lot more before we can decide on what would be best for you and your symptoms. There's also bioidentical hormone therapy, which is compounded by a special pharmacy. It may include hormones such as estrogen, progesterone, testosterone, and DHEA, which is an androgen, similar to the testosterone family. Other medications, if you're not interested in hormones, is things like antidepressants or vaginal creams to help try to treat vaginal dryness or atrophy. And I'm sure you all have been familiar, probably, or Googled Dr. Oz. And so there's lots of different things out there that they say on the internet, you know, black soybeans, coconut oil, chia seeds, dark chocolate, red wine, eggs, beet juice, sweet potatoes. Statistically, I can't say that any of them work, but I don't see why trying them would hurt. So if you want to try them, great. And I always ask patients to give me feedback, what works for you, so I can maybe pass it on to someone else who's dealing with the same symptoms. This is the main component of the perimenopausal phase, and the most complaints that we get in the office is just people forgetting that we're here to help you, and that thinking that this is normal is just something you have to suffer through. You don't have to suffer. We're glad to see you, any OBGYN. This is part of our practice. This is our goal, is to try to ease these symptoms for you. So there is our talk about perimenopause, and I'm going to hand it over to Dr. Colruyt as she talks to you about our next topics.
Thank you. Okay, we're going to switch gears a little bit. I think I might just come around this way, maybe. See if I can figure out. There we go. We're going to talk about incontinence. Anybody here have incontinence? They're not going to say it right now. Okay. The first type of incontinence we're going to talk about is stress incontinence. This is unplanned urination, which usually happens with coughing, laughing, sneezing. A lot of women say it only happens when they get together with their girlfriends and they're laughing. A lot of my patients say they notice it when they step off the curb. But this is also the most common type of incontinence in younger women, and it is extremely common. Causes of stress incontinence: weakening of the muscles and the supporting tissues of the bladder. There's an increase in pressure of the bladder that is greater than the urethra, which is where our urine comes out. Pregnancy is a major risk factor, especially if we have vaginal deliveries. Weight gain is a risk factor, obesity. Also, sports injuries. When I saw that on the slide, I don't really think about sports injuries causing incontinence. Maybe Phyllis might know a little bit about that, but definitely women who are in work situations where they have to lift a lot, they frequently would have stress incontinence even if they haven't had vaginal deliveries. Urge incontinence is the second type of incontinence we're going to talk about, and this is where you have a really strong urge to urinate and you're not able to make it to the bathroom in time. It's oftentimes associated with overactive bladder. Some women have overactive bladder and they're still dry. They're probably happier than women that have overactive bladder and they're wet. But majority of women with overactive bladder probably have some urge incontinence. They might lose urine when they hear the water run, or they step into the shower. Oftentimes they're standing at the kitchen sink and turn the water on and they just go crap, and they lose a little bit of urine, even though they know they should be able to try and control it. And sometimes it's a large amount. It tends to be usually a small amount, but sometimes it can be a large amount. So causes of urge incontinence, spasms of the bladder muscle is the primary cause. It may be due to damage of the nerves or the muscles supplying the bladder. For the most part, I think it's associated with aging. We always rule out infection when we're evaluating for incontinence. That would be a very easy thing to correct. Damage may also be caused by a stroke or inflammation, infection, again, they're talking about there. The emotional toll of infection, obviously it affects a woman's overall well-being, and women with incontinence have a higher incidence of low self-esteem, depression,
certainly it impacts our sexuality. A lot of women say they don't want to have sex because they lose urine either during sex or with orgasm, and they're worried about odor and so forth. Isolation is what we're talking about. So diagnosing incontinence, there is specialized testing that can help establish the diagnosis. Usually we begin with your diary, your voiding diary, your symptom diary, I should say, and then rule out infection, do a physical exam, of course, to see whether or not you might have pelvic relaxation, uterine prolapse, cystocele, and then beyond that, there are bladder tests that we would complete in the office. We call it urodynamic testing or bladder testing. It's a non-painful way of evaluating the bladder. I do it in my office, and one of our other partners also does urodynamic testing. It takes about 15 to 20 minutes, and it's not a painful procedure, and it's the physician and the nurse filling your bladder up with fluid and then evaluating the bladder as it fills with sterile fluid. And it helps us to decide which way to proceed with your treatment. These are some of the things that we can do for managing mild incontinence. So drink less fluids, which I don't think anybody really wants you to drink less fluids, perhaps late at night. Drink less fluids, avoid caffeine. Coffee, tea, sodas are particularly irritating to the bladder. Caffeine is a diuretic. Emptying the bladder regularly. The goal is to try to work up to 4 hours, but many people, it can't get beyond 30 to 45 minutes without having to go to the bathroom. And we're moving on to Kegel exercises, which I think Phyllis is going to maybe give us a little bit of guidelines here too. Probably most women have heard about Kegel exercises. These are exercises to tighten the muscles that we use to stop the urine flow, and there are various ways that it can be done. But the goal is to try to hold those muscles for 10 seconds and then relax, and to do several sets of these throughout the day. I've always been told by the super experts that you should not do this while you're sitting on the toilet, because that can confuse the brain. Is this a good point for you to step in, Phyllis? Do you want to talk about Kegels? Sure. And then I'll come back. We'll finish up with some more.
Okay.
Sure.
Okay.
Thank you.
Okay, Nan just asked me to come in and talk about the program that I have at Riverview Aspires Riverview for the treatment of urinary incontinence, and I also treat fecal incontinence as well. I've been doing this program for close to 20 years, so it's been around for a long time, but I think it's finally starting to become a lot more, people are becoming more vocal and seeking out help a lot more, so I stay pretty busy in the clinic with it. But my program is basically a self-help program used for the treatment of urinary and fecal incontinence. And by being self-help, what I do is see my clients once a week, sometimes once every other week, just to progress, see how they're doing, what do we need to focus on this week, and then I give them homework. And that's where the self-help part of it comes in. Because I'm not going to get anybody better in the clinic without them doing the exercises at home. And the Kegels are what we're referring to. What I do when I see my clients in the office the first time is I do an initial evaluation of the pelvic floor muscles by doing an EMG assessment. And based on what I find with that, then I establish an exercise program. And the exercises are based on the Kegels philosophy. And there's a variety of different things that I do with that. And again, it just really depends on what each person's individual needs are. So it's hard for me to just stand up here and say, okay, this is what you should do. But I agree with Dr. Colruyt. I tell all of my clients if I'm having a hard time getting them to understand that pelvic floor contraction, I will give them the green light to do it on the toilet once or twice, like as you're urinating, make that attempt to stop. That is what that contraction should feel like. But because of an increased risk of infection and such, I don't recommend that they do that on a regular basis. What I do is I assess that ability of the muscle to contract, because that's very important. I assess the endurance of that muscle, how long are they able to hold it, because that's going to have a huge impact on urge incontinence, but also stress incontinence as well. And then equally important that I don't think a lot of people think about is I focus a lot on the relaxation of the pelvic floor muscles. It's so important that when you need those muscles to contract, if you're going to cough or you're going to sneeze, or if you sneeze and you know it's coming and you can kind of brace yourself to keep yourself from leaking, if those muscles have been contracted more than they need to be, they're so fatigued that when you need them to kick in and help out, they're just not there. So the relaxation phase is surprisingly a really big part of what I do with all of my clients, because so many people, especially as you start to leak, you start to have less confidence in your ability, and even subconsciously you may be contracting those muscles, not even realize it. So each time that I see a client in the clinic, I go through a biofeedback assessment, and I always make sure that any exercise I give, I'm doing through the biofeedback so that I and the patient also can see if it's being done correctly. Each session focuses on the exercise portion, but we also look a lot at lifestyle changes, things that can be done differently that may help, may or may not. And Dr. Colruyt touched on a few of those in terms of watching caffeine. I actually encourage a lot of my patients to drink more, because that really affects the urine. When you are drinking less, it becomes more concentrated. That can be very irritating to the bladder wall. But I do talk about timing and what to drink and things like that. But there's a lot of little things that may help, it may not. But I always ask my clients, just give it a try for a week, and if it doesn't make a difference, you can go back to what you were doing before. So typically, my program is short. I mean, I see people most often 4 to 6 visits is all that I need to do, because really all I'm trying to do is establish a program that you can follow through with at home. This is the one thing as a physical therapist, and I treat all different problems. This is the one time that I tell my clients this is a lifestyle change. This is something you're going to have to do for the rest of your life. If I see you for knee pain, you may not need to do those exercises forever, but I do really stress that with this. So again, the Kegels, I usually have people give me, I do a variety of different exercises, so they're probably doing anywhere from 4 to 6 different exercises, doing that 3 times a day, 10 reps of each one. So it's really building up, but I start out slow and build up from there. So if you're new to it or just starting, my recommendation is just to start with, 10 reps, maybe try that 3 times a day, and if that feels like it's going okay, you can always increase it from there. But I focus on, I do quick contractions, I do longer holds where I encourage holding for 10 seconds. And then I also use other tools within the clinic and things that I send home with my clients. So I think the good news is that the word is getting out there. There's a lot of help that can be given to a lot of women. This is something that you shouldn't have to suffer with. So
Thank you. Thank you, Phyllis. Let's see where we left off here. I think we have a little bit left on incontinence. Treating incontinence, we talked about Kegel exercises. Some women would be, and further treatment with our physical therapist, some women would be a candidate for a pessary. That might come around again. Can you ladies over here if I do it this way? Okay. A pessary is a device that helps reduce leakage from incontinence, can be worn continuously or just as needed. This is mostly something that would be for my older patient. bladder training. We talked a little bit about that with Phyllis. Medications, there are several medications that are used for treatment of overactive bladder, and they're effective when combined with bladder training. And lastly would be to talk about surgical options. Surgical options might include a sling procedure or might include an implantable device called InterStim, which is basically like a sort of a pacemaker for the bladder. We're not doing that particular procedure at Riverview, but we do have providers in the Aspira system that do that, urologists that are knowledgeable with InterStim. So prevention, let's see, I forgot to mention Botox for the bladder. That's the other new treatment, which I have not gotten involved with Botox in the bladder, but our urology colleagues can offer you that in the Aspira system. So prevention, maintain an appropriate healthy weight, perform your exercises regularly on the pelvic floor, avoid smoking. Part of the problem with smoking is that it causes a chronic cough, and a lot of those ladies do have leaking. Speak with your doctor about any concerns that you might have. I think that wraps it up for incontinence for the most part. Let's see. I think we've got a couple things in here about our Medi-Spa. We just wanted to make sure that everyone knew we have a Medi-Spa, which opened 2 years ago? A couple of years ago. And our products, our esthetician is not here tonight. She just got back from maternity leave this week. Otherwise, she was going to be here tonight too. But services and products include Botox, which I'm the only person right now doing Botox injections. Maybe Jen is going to learn, I don't know. Also, we offer fillers, and these are facial fillers for fullness in the face. These are temporary. The results last 1 to 2 years. And the silk peel, which our esthetician does, that is a mechanical peel with a diamond tip, great for the skin. She also performs the chemical peels, which are the two listed below. And my favorite is that VI peel. I love that thing, the VI peel. It's amazing what it does for your face. Baby foot is a peel for the foot, and that's amazing too. And then she's got products for the skin too, so those are listed there. This is showing a patient who had cosmetic filler and the before and after pictures. And the filler was placed between in the nasolabial fold and also in the marionette lines, which are the lines coming down from the corner of her mouth. And I think this is the last one, is showing another cosmetic filler. Same thing, nasolabial folds and down below the corners of her mouth. This is a fella, I believe, which we don't treat in our spa. But this is showing Botox. And they call the frown lines, we call the 11 lines. And so he got a good result from his treatment of those lines between his eyebrows. That's a very popular treatment area. That's FDA approved for treatment of these frown lines between the eyebrows. This is showing a patient who had some scars from cystic acne. And so she's had several VIP peels, probably several, I'm guessing. And you can see that her skin really looks very nice on the right. And that, maybe this is another one with silk peel, someone who's had some scarring from sun and aging and maybe some acne. And these peels, they don't hurt. They don't hurt. Oh, there's my nurse. I didn't know she was in here. This is my nurse, Sue. She's not here tonight. I'll have to tell her about this. Jen, our esthetician, does makeup. She does it for weddings and all kinds of things, but here she did a before and after on my nurse, Sue. Okay, so questions? Sure. Come on out, Jen.
I'm not answering now. You're not? No.
Okay.
Sure.
When I was 43, I had a hysterectomy, oophorectomy. 20 years later, I'm getting hot flashes. Is that possible?
Could you repeat the question too in the mic so that probably with you
Sure.
At least it feels like it. I get hot and I get cold because I've sweat.
Yeah. She's asking if it's possible to get hot flashes 20 years after you had a hysterectomy and removal of both the ovaries. In the time in between, you didn't have any hot flashes? I mean, it is possible. It is possible. It's one of those things I would want to visit with your doc or your primary care provider about. Could it be medications? Could it be anything else? Could it be stress? Could it be infection? It's unusual, but it's not impossible. Right.
By the way, ladies, we put index cards in your folders in case you wanted to ask your question kind of anonymously. So if you want to write a question down and just send it down or hold it up, I'll of course, it's not so anonymous, I guess, if you hold it up. Unless a lot of you do it, and then I shuffle them all up. So come on. That's what these doctors are here for, is to answer your questions.
Yes. Yes, diabetes does affect it because it plays with your glucose, and if you have any overweight, extra adipose tissue, you have extra estrogen. So there are a lot of effects that our diabetic women come in complaining of, and it has to do with a combination of that whole axis on the pituitary gland that plays on the ovaries, and then other additional health risks that we talk about. So we try to maximize the best results for each patient. But yes, I do see a lot of patients coming in who are diabetic with exacerbated complaints.
What else can put pressure on the bladder? Is there any organ or that can put pressure on the bladder organ?
So pressure on the bladder, that's a good question. So normally it's the uterus, some component of the uterus. No, but that's not all. There's the bowel right there. So you kind of got a sandwich effect. So bladder, uterus, bowel. So if you have any type of bowel abnormality, if you have chronic constipation, IBS, ulcerative colitis, things like that, you can also have bladder symptoms associated with that. So we always try to, those are the three areas we always look at when people come in complaining of different things. We don't just always assume that it's our field. We double check that, but we know in the background that there could be other areas such as parts of the bowel.
Can that be discussed with you?
Yes, of course. If you're coming in with that, I'm going to ask you lots of questions. Get very personal with you and ask you about bowel habits and look at your medical history. And if it's outside my scope, or I don't know how you do, then if I feel like you need to see a GI specialist, then that's where I'm going to send you next after I document everything, because unfortunately, I'm not a bowel specialist. Okay.
No, she's staying right here.
So. Yes.
Can you go through all of the effects of libido when you're going through your perimenopause and menopause?
Sure, I'd be happy to talk about that.
You embarrassed.
Oh, no.
There's just lots of effects.
There are lots of effects, right? So, yeah, libido, I mean, it is pretty common. It's natural that it is going to decline as we age, at least for most women, and men actually too. For most people, it declines as we age. But there are so many factors, depending on your health, and whether or not you have the right vaginal lubrication. Maybe you need some local estrogen, so it's not painful when you get together. There's a lot of factors with libido. I thought maybe you were going to ask about are you interested in hearing about the female Viagra? Right. Because this came out last year, and everyone was very hopeful that it was going to help with libido, but it turns out it really doesn't compare at all to what the guys have, Viagra and Cialis. It doesn't work the same way. It works a different way. It affects our dopamine and our serotonin levels. It doesn't appear to be at all what people were hoping it would be. There's still ongoing studies going on, but it's only going to increase a woman's satisfactory sexual events 1/2 to 1 event per month over her normal 2 to 3 per month. It's not recommended for women that are postmenopausal. It's not FDA approved for that. You can't drink alcohol with it. It makes you dizzy and tired. What was the other thing? Oh, the other big thing is it has to be taken every day. The medication is called Adeine. Is that how you pronounce it? I think that's how it's pronounced. It has to be taken every single day. It's not just taken for the event like Viagra or Cialis. So if you were taking it every day and you're paying out of pocket, it's $400 a month. For half of an orgasm,
It's not worth it.
There's got to be something better, right?
Yeah.
But I would say to you that yes, we usually if you came in and you were talking to me about that, I would say well, let's check estrogen level, let's check testosterone level. Maybe you need some help in that area. Maybe you need some hormones, and make sure that you have enough vaginal estrogen to enjoy intercourse.
Well, I think we just want to go back to the men and say, yes, it really is true that we really don't care anymore about it. It's all in your head. You gotta be in your head with it.
All right, we got some questions up here. So this question says, I had a hysterectomy at age 32. Uterus, cervix, and right ovary were removed. I haven't had a pap smear or exam since. I still have my left ovary and have had no hot flashes. Do I need a pap? That's a good question. So depends on your history and the reason for why you had your hysterectomy. If you've never had an abnormal pap and they were doing it for other reasons such as fibroids, endometriosis, things like that, you don't necessarily need a pap, but you still need a yearly exam, including a bimanual exam, and someone to evaluate the external parts of the female genitalia. So the vulvar is what we want to look at, the labia, all that area, to make sure that you still are maintaining good genital health. So I would say yes. So give us a call. We'll gladly see you. All right, what?
Your day book.
Yeah. Just give us a call. We'll fit you in.
There's actually information in the folder. You want me to do that? Of how to contact them.
Okay.
Yeah, go for it.
Oh, okay. The next question is, can you go into more detail about surgical options for urinary incontinence? So there's multiple different, depending on what your cause is first. Do you have stress urinary cause? Do you have a hypermobility of the urethra where it's moving too much? Do we need to do a sling that supports the urethra so it's not moving as much every time you urinate? So there's all different types of slings depending on what exactly your urodynamics show, which way we do it, or if you're an athlete, things like that. The other thing that causes some stress some urinary incontinence procedures is sometimes the anterior wall of the vagina lacks the muscle strength, kind of decreases, and you have a bulge, which is called a cystocele. So we call that an anterior repair. If there's any type of prolapse that you're having in addition to urinary incontinence, sometimes we have to do something called like a pelvic prolapse suspension surgery. So it's kind of pulling the vagina back up and elongating it so that you don't have that bulge. So there are multiple different procedures that you can do, such as sling, anterior repairs, and suspensions, but it all depends on what your exam shows. And normally there's multiple causes for your urinary incontinence, so we kind of go over that while we evaluate you and talk to you, but there are multiple options.
Do you do the surgeries?
We do slings and anterior repairs. I do not do suspensions. Do you do suspensions?
If a person really had complete vaginal vault prolapse, where the top of the vagina is falling out, that's usually best done now by a robotic procedure with a graft. And so no, we don't do that at our hospital.
Mm-hmm.
Yeah.
What about that surgical mesh that they had for a while, and then all the
FDA?
lawsuits and whatever? When a person has something like that, and you go in and you find that some of it has come apart,
Mhm.
and you get it taken care of, now someone is saying that they're hunched over more because when they stand erect, it feels like it's pulling and gripping. And is that really true, or is that?
I'd be happy to talk. Yeah, I was involved with a lot of those procedures actually in Denver with a urologist. The gynecologist would do the hysterectomy. The urologist would do the sacrocolpopexy. It's a very nice procedure for women that need it. I never saw a patient that was bent over, but you know, obviously there's some finesse in knowing how much graft material to place so that it's appropriate. But I never saw a patient have that kind of a complication. Now, mesh is a different subject. We're not talking about sacrocolpopexy, but mesh, where they were using it for Rectocele and Cystocele, that really is kind of on hold for most centers right now because the FDA is still looking at it. It's being used only in university settings and research areas.
They also said that there's a possibility that would actually grow into your organs and cause major problems. That is also true.
No, that is true. There have been problems with mesh. That's why it's been on hold really since 2012. So, but that is separate from what we're talking about.
But how
That
does
slings.
an older person go about trying to get healthy again after something like that? I mean, when you're in your 80s and a
Right.
person is saying, you got to go for surgery, you got to go for surgery, and every time they go for surgery, they end up almost with pneumonia and almost keeling over from. How do you combat?
Clearly, that patient would need to see a urogynecologist who's had a lot of experience. Right. Yeah. What causes difficulty to start urinating? And what causes difficulty with emptying? Both of those can certainly be related to pelvic floor relaxation if a patient has a cystocele where her bladder's falling down into the vagina. She may need to adjust herself on the toilet or even apply pressure in the vagina just to get the urine to come out. And then after she starts voiding, she's kind of got to do a little dance up above the toilet, sit down, finish, stand up, sit down and finish. So all of that has to do with the bladder dropping down. And that is corrected either with a pessary or with surgery. So I think that's mostly what she's asking about there. Okay, last question from this patient. Is it true if you are not sexually active, women close up and become tight and lose it? Like men do. Use it or lose it. I like that. Oh, that's great. That is great. Well, basically it is true. The vagina without estrogen goes back to being like a 10-year-old. Especially if you're not using it at all, right? So, there you go.
Does the tampon type device that's advertised on TV really work for incontinence? This is very interesting. I get this question a lot. So I have quite a few friends, and people that I've talked to who use this, and they say they love it. They've only used it for exercising when they know they're going to be doing jumping jacks, things where it's high impact, and they say it's an easy insert like a tampon, something they can do themselves, and it actually has decreased their urine output during those events. Now, I don't know about wearing it all day long and what the outcomes are with that, but I've heard positives. I have not seen any statistical reviews whether it is truly worked or if it's just a placebo effect that they're noticing, but I would believe that if it's supporting the urethra and your only problem was stress incontinence, then you would have some improvement with it.
What is this? Can you describe it?
So it looks like a tampon.
It does. I recently just looked it up, and I almost tried it for running, but I didn't. But it looks like a tampon. But it's got like a square in the front with a smaller square in the back. It's got a string on it, just like a tampon. And I assume you would leave it in not more than, well, you're not bleeding, so maybe it doesn't matter. You could leave it in all day, I guess. They're kind of expensive. It comes out to almost $2 a device.
Yeah, device, I think.
Right. So, but I would think that it might work well for a lot of women. Otherwise, they wouldn't have brought it to the market.
Yeah. Let us know if you try.
Let us know.
What is it called?
It's called
Poise makes
Poise. Poise is the maker. Poise is what? Poise Precise, maybe?
it. Yeah.
Poise. Right.
So it's right by the urinary incontinence briefs and pads. It'll be in that section, and it's made by Poise.
Last one, I think.
So this question is hormone therapy really safe, or does it increase one's risk of breast cancer so that it might not be safe? This is a loaded question. So, is hormone therapy really safe? So, this is why we have you come in to talk to us. We need to know your personal history, your family history. Have you been up to date on all your screening? How old you are, what your symptoms are. In majority of women, hormone therapy is safe, but there is always risk with any medication that we have to talk about. So does it cause breast cancer? No, but if you get an estrogen sensitive breast cancer, will it accelerate it? Yes. Okay, so it does not cause breast cancer, but we don't know who's going to get breast cancer, and we don't know what hormones that breast cancer is sensitive to. So when you have those discussions with your provider, we go over that, or at least we should go over all the risk with every type of hormone, review your family history, your personal history, things like that. And I am very adamant about making sure that people fully understand the risk and benefits so that you can make a choice. Is it something you're willing to do because the side effects or the symptoms that you're having are so severe that you're just not able to function? So I hope that answers whoever asked this question. Anything else for us?
I was just going to add with the hormone replacement, because I am a fan of hormones. I think the thing that women need to know too is that most women are only on hormones for a couple years. Average time is 2 years, maybe 3 years. So, and the risk that is associated with taking postmenopausal hormones comes maybe at 5 years, more like 10 years. So if you're only going to use them 2 years and your doctor or your healthcare provider thinks you're a good candidate, then your risk really is pretty minimal if you're only using it a couple years. Yep.
Could you?
No, we have no reason to think they're safer. Oh, I'm sorry. She asked if bioidentical hormones are safer. There is definitely a myth out there that women think they're safer, but we have no clinical information to prove that they're safer. So we assume that they have the same risks as other hormones.
We also don't know because they're at a compound pharmacy. They're not FDA regulated, so we don't know the exact dose you might be getting. So there is some unknown component of that, which is okay if you're willing to take that risk. But again, compounding pharmacies don't fall under the exact same categories that like the pills that we prescribe, like S-Trace, things like that. So I think it's a personal choice.
Someone
And then-
else in the back had a question too.
What are your thoughts or feelings on like natural remedies for menopause? So you don't have to take like antidepressants, like
I'm open to it. I have a lot of patients that use essential oils or they take different minerals and they say they feel better. So I think as long as you're okay with any risk associated, because again, we don't know minerals, things like that, what's out there literature-wise, but if you're okay and you want to approach it naturally, by all means. Hormones are a choice, and same with every other treatment option. It's a conversation you should have with your provider so that you're both on the same page and know what your goal is of the treatment. So.
Is Premarin still on the market? Premarin.
Yes.
Repeated this.
She asked, is Premarin still on the market? And the answer is yes, Premarin cream is still on the market.
Do you know how they make it?
Yes, I do.
That's why I asked. Okay.
All right. Let's give a big hand to Dr. I'm not letting them off the hook because they will be drawing for door prizes in just a minute. I want you to know that one of my coworkers, I lost it. I have her picture of her daughter now. She actually looked it up online. I would pronounce it probably Posey, but it's made by Impressa.
No, it's Poise.
Poise, Impressa, bladder supports. So they have a website at poise.com.
Just Google.
In case you want to Google it on your phone. I just want you to know that during that time, I had no wine, no excessive amounts of alcohol, but I got hot and cold all at the same time. Okay, so before we move to the door prizes, I wanted to introduce a couple of people. We have two Marys here. Are you in the audience, Marys? Mary's from Aspirus Point Clinic, Mary Regal and Mary Elliott. There she is. And Mary Elliott. They're both from our Aspirus Point Clinic.
Yay!
My lovely coworker up here is Tracy Weiss, who makes sure that everything happens. Tammy Barber over there. And I would be remiss if I didn't ask our aspiring a cappella group to come back and sing on this side of the room. So, while we're drawing for door prizes, they're going to do that. I want to also extend some real thanks to Phyllis for coming out also and helping you understand that it doesn't necessarily take surgery to fix a problem of incontinence. Okay. Yay! So she is getting a gift basket from Ruby Reds. All right, Dr. Colroot, you get to draw the next one. Oh, it's out the bar. What are they doing out the bar? Didn't we just talk about excessive alcohol? All right, ladies, so after our a cappella group, our aspiring a cappella group sings to you once more, then as you leave, we do have an Aspiring Women gift for every one of you. It's kind of spicy, so don't eat it all at once. I thought that was great that we served spicy food out there when they told you to avoid spicy food. And we had drink specials when they tell you to avoid alcohol. At any rate, we want you to turn in your name tags, because we do use them again, and pick up an Aspiring Women gift on the way out. But first, let's listen to our lady singers.
I was afraid, I was petrified. My mother said I was a woman, she was filled with pride. But now the cramps were setting in and my emotions running high. I used to cry and didn't even know why. Hormones were high, was blurted too. I never knew that puberty could be so hard on you. Why are my pants feeling so tight? How did this hair get on my chin? With all these changes going on, I wasn't sure how I could win. And now I'm off.
And now she's off
to my exam.
To her exam.
Don't wanna have another pap smear or a mammogram. Weren't you the one who said I might pee when I sneeze? Or have a hot flash? Oh, Dr. Pretty, please. Oh,
till the menopause kicks in, I'll survive. I will survive. I will survive. I will survive.
Thank you, ladies, for coming, and stay tuned for future events.